Good morning, everyone. This is Jason Helgerson. We're just going to give, we have a lot of people sign up for this, like 1,500 or so. So we're just going to give folks a couple more minutes here to sign in so they can hear the entire webinar. Thank you very much for joining us this morning. Hello, everyone. This is Jason. We're going to get started in just a couple minutes. All right. Good morning, everyone. This is Jason Helgerson. So pleased to have so many folks interested in hearing this webinar. In addition to it being live this morning, we also will be taping this particular webinar and will be available on our website. So whatever you are. So we have a problem with the phone, which is that someone is not on mute. So if everyone on the phone could please put their phones on mute so that's the benefit of everyone else that they can in fact hear. Thank you. Okay, so we're starting and a lot of important information here. I know it's been a topic that a lot of folks have expressed interest in, and so we're very pleased to have this opportunity today. Joining me is Liz Misa, a deputy administrator here for the Medicaid program and has been our lead on social determinants of health issues. And so it'll be the two of us doing most of the speaking today. At the end of this, we will be answering questions from folks via the web chat function as part of this webinar. So thank you once again for your participation. Jeez. There we go. So also please, for folks, please put your phones on mute. We can hear some background noise and it's very distracting for anyone on the phone. So please put your phones on mute. Thank you. We can hear someone moving and rattling some papers and things like that. So the agenda for today, after some introductions, we'll talk about what the roadmap in value-based payment. And for those of you who are particularly interested in this topic, we do strongly suggest you read the roadmap, which is available on the website. The second version of it was approved by CMS. Hold on one second. We'll try to work the fix the audio for a second, see if we can mute everyone. Hold on. All right, apologies to that. Hopefully we've muted all the lines, so as a result, we won't have any background noise. We know that it's very difficult for folks to hear if there's background noise. So as I was saying, we're going to go through the requirements of the roadmap and hopefully encourage folks to read the roadmap. In addition to participating in webinars such as this, the other thing I would like to strongly promote is for folks to participate in the VBP University. We're rolling out that curriculum. It's an online educational opportunity for folks to learn a lot more about VBP. Just yesterday, I believe, we released the second semester of this. We're actually going to develop a semester specifically around this topic. And so look to see that in the coming weeks. So really, there's sort of two topics we want to talk to, although they're clearly related. First and foremost is social determinants of health. New York is a national leader in this area in terms of the Medicaid program, and there's a number of different programs and projects that we've launched over the period of the last several years. But in addition to that, also within the context of VBP, we're also a national leader. We are the only, as far as we can tell, the state Medicaid program that actually has requirements for VBP contractors to actually specifically identify and engage in addressing a social determinant of health, and then actually to contract with a community-based organization to support that effort. So we're excited about that. That's why we're so excited to have this opportunity to talk particularly to community-based organizations, because I think it's a great opportunity for contracting between these organizations, which in many cases are culturally and linguistically competent and bring years of experience in working with communities who are particularly challenged by the social determinants of health. So very excited. Then we'll get into some specifics around contracting and then close with a few final comments before we open it up to questions. So once again, it's me, Jason Helgerson, and Liz Misa, who are going to be your presenters today. So in terms of our goals for today, and the real purpose for this was really to engage particularly community-based organizations, but maybe also others who are interested in this topic, on what social determinants of health are within the context of VBP, what we're trying to achieve in this important area, and then what role we see for the community-based organizations. As I said, we're a national leader in this area. We have requirements in our roadmap that no one else in the nation is attempting. So we're very excited to be at the forefront of the country in terms of using CBOs to address the social determinants. We're going to go over specifically what's in the VBP roadmap, and then share some examples. And this is a 2-hour webinar, partly because we have 2 videos that we're excited to show, which talk specifically to some examples of what CBOs are already doing to support and address the social determinants of health. It gives providers plans as well as CBOs some food for thought relative to what potentially could be done in this important area. But really, ultimately, at the end of the day, what we're hoping for and our goal is to really begin to see more collaborations between the plans, providers, and the VBP stakeholders in terms of moving forward with contracting. There are specific, and I'll talk to those in a minute, requirements on plans and providers relative to addressing social determinants and contracting with CBOs. So we're really seeing this as hopefully an important kickoff to a renewed effort to begin to get contracts between the organizations in place. All right, so I think it's important to put value-based payment in the context of our broader Medicaid redesign efforts, which really date back to 2011. We sort of see this as a 3-phase effort. Phase 1 was Medicaid redesign team and its efforts to a great extent, that which began in January of 2011, and we're still in the final stages of implementing some of the elements of that 5-year action plan. Was really about trying to make the Medicaid program more cost effective. To a great extent, as I said, most of those initiatives are now in place. We've definitely made the program more cost effective. We're spending less on a per recipient basis than we did a decade ago. And we're quite proud of the success and progress to date. That said, Medicaid is but one payer in New York State, and ultimately our ability to be cost effective as a program to effectively meet the needs of the 6+ million people on the program is limited by the healthcare delivery system itself. And if that system is inefficient, it is not capable of generating the kind of outcomes for our members that we're looking for, there will be limits in terms of what we can do as a standalone program. And that's really where DSRIP comes in, which is delivery system reform. And the idea is to try to get healthcare providers working together as integrated teams. We have 25 performing provider systems, which were launched starting back in 2014, really as an effort to try to get the healthcare delivery system to be much more efficient and effective. But right close on the heels of that, and actually a requirement of the waiver that governs the DSRIP program, was the need to move to value-based payment. We're under an obligation with the federal government through that waiver to move 80% of our payments to value-based by the end of the waiver period. We right now, and we've been doing surveys basically catching up from years starting in 2014 through 2016, and about a third of our reimbursement in the most recent survey, 2015, that we've compiled, shows that basically about a third of our payments to providers are value-based. So we aren't starting from zero, but we do have room to grow and room to move, and it's going to be a major focus of the health department, is really to support providers as they move to value-based payment. And I think it's part of the reason why it's so important for us to have this discussion today around social determinants and CBOs, is because of the role that these organizations are going to play and the requirements that are in the roadmap. So for those maybe a little less familiar with the roadmap itself, it is a governing document for how value-based payment will be done in New York State. As I say, we now have a second version of the roadmap that's been approved by CMS. You'll see in that document two types of requirements or guidance, statements of policy, if you will. One of them is what we call a standard, and a standard is an actual requirement that could be applied to a provider, could be applied to the plan, or in some cases actually applied to the state. But it is not optional. So a standard is sort of a higher threshold in terms of policy. The other thing you will see are guidelines, and those are things we suggest that we think is the best direction moving forward, but we give some greater flexibility. The way we see the roadmap is that ultimately, at the end of the day, it is a series of options that providers and plans have with some specific requirements. But generally, we try to give providers and the plans the opportunity to tailor value-based payments in ways that best meets the population as well as the community. Value-based payment is a major change in reimbursement systems, and requires providers in particular to, in some cases, change their business model in order to be successful. It requires a level of collaboration between organizations that historically has not been the case. And it does require a new set of activities on the part of plans. So we are fully aware that this is no small transition, and we also are fully aware that New York is a very large, complex, and diverse state. And providers are coming at this, in some cases, with more than a decade's experience in value-based payment, while there's others who are just learning about it for the first time. So in that environment, we have to, we think, give flexibility so as to ensure that we do not have, as a result of a one-size-fits-all approach, unintended consequences and major disruption that we all, I think, collectively want to avoid. But in terms of social determinants and CBOs, there are some important standards that we want to highlight up front here. So first and foremost, VBP contractors in levels 2 and 3 arrangements must, and I repeat, must implement at least one social determinant of health intervention. You can find that on page 41 of the roadmap. This is, as I said, an area where New York is a vanguard. As far as we can tell from checking around the country, we don't know of any other state Medicaid program that has a similar type arrangement. So we will, in fact, through the plans, be tracking what arrangements are entered. And for those that are levels 2 and 3, meaning these are risk arrangements where in level 2 and 3 are where there's upside and downside risk. So these are more sophisticated providers. We will be asking the plans to track which social determinant those providers and plans in concert as part of those contracts are in fact addressing. So that's first and foremost. Second is that providers, including CBOs, will incentivize by MCOs upfront to identify social determinants and be financially rewarded for success in addressing them. We want the MCOs to have the opportunity and resources up front, the CBOs to have resources up front to really work with the MCOs and the other providers to address these issues. And we understand from a cash flow standpoint that contracts need to be signed. It's important to point out that we are not saying that CBOs themselves have to take on financial risk. We know some CBOs are financially challenged and aren't in a position to take on risk, and so there's no obligation that they do so. They can sign a traditional contract for a particular intervention to address social determinant. Some CBOs may want to, maybe a level 1 arrangement where if they're successful and they help the VBP contractor lower total cost of care and improve outcomes, they may want, as part of their contract, to have, say, a bonus added in, but want to be clear, there is no requirement in the roadmap that they actually do include, or that they actually address that in terms of having that financial stake in their direct performance. Providers receiving funding for social determinants of health must report to DOH on fund utilization. We do want to track this. As I say, we're a national leader in this, so we do want to see which interventions were used, which ones were effective, so that if there's best practices that come out of this this effort, that we can share it across the rest of the state. The roadmap does also provide some guidelines. As I say, they are not fast requirements, but they're certainly recommended practices. And first and foremost is to allow flexibility in selecting social determinants and support effective implementation. We are fully aware that while there is some body of evidence that suggests certain interventions are effective, there's still a lot that needs to be learned in terms of how to effectively address these. We also know that the population and the communities are quite diverse. So we are going to give plans and providers the flexibility, and CBOs the flexibility, to identify interventions, scale them as appropriate, and learn from those experiences and adjust them over time. We had a work group that came up with what ultimately were these recommendations, and they compiled, we'll talk about that later, a pretty robust list of interventions for which there is some evidence. But we aren't dictating to CBOs and contractors and plans what types of arrangements they need to, and what types of interventions they have to do. Also, in the roadmap, it guides contractors to report to the state on the selection of their interventions and a report on success. We definitely want to track this, as I said, and really stay on top of it. And as I say, share best practices with the field. In terms of CBOs, another unique to New York aspect is that for any of the level 2 or 3 arrangements, that in those more advanced forms of value-based payment, we expect them to actually contract with a Tier 1 CBO. We'll talk a little bit about what a Tier 1 CBO is, but generally speaking, Tier 1 CBO is one that does not provide services to the Medicaid program. These are community-based organizations, perhaps funded by local governments or philanthropy or other forms of grants and such, but are not a Medicaid certified provider. That they must contract with a Tier 1 CBO to address the level 2 and 3 arrangements. We are very interested in tapping the cultural competence and linguistic competence that those Tier 1 CBOs offer, and that is why this is a standard approach. Now, we do not say what that arrangement is, the size of that arrangement, the financial nature of the arrangement, and certainly we, as I mentioned earlier, we are not dictating what type of intervention that CBO will do. But there is a clear expectation and requirement that that a contract be in place with a Tier 1 CBO. And then also we encourage the MCOs and contractors to measure the success of the intervention and use, when appropriate, patient-reported outcomes. PROs are a very interesting metric. We had a much discussion about whether PROs should be adopted more universally. We are interested in providers and plans and CBO contractors piloting it. It's used mostly when in the United States, it's used mostly with regards to research and studies, particularly ones that are looking at, say, new prescription drugs or other types of treatment. And when it's used, at least what we've heard from the field, is that particularly providers find that feedback very, very useful. It is used more extensively in other countries, in particular in the UK. So we're interested in providing opportunities or encouraging people to use it if it's appropriate. It's not a hard and fast requirement. It is a guideline, but it's something we will definitely be looking for early adopters on. All right, so next up is Liz Misa, and I'll turn it over to her to talk specifically about social determinants of health. Liz?
Great, thank you. So as mentioned in the roadmap, VBP contractors in level 2 or 3 arrangements must implement at least one social determinant of health intervention. And language fulfilling this standard must be included in the MCO contract submission to count as an on-menu VBP arrangement. As also stated in the roadmap, level 1 providers will get an additional bonus if they address at least one social determinant of health, and level 2 and 3 providers will receive a funding advance to provide investments or seed money if they commit to addressing one or more social determinant of health interventions. So to ensure compliance with social determinant of health requirements, MCOs must report on fund utilization to the department. Information required will include why the social determinant of health intervention was selected and identify metrics that will be used to track its success. The department is going to provide a social determinant of health intervention template, which will be located on the provider contract guidelines website of the department to help clarify the reporting requirements that are needed. And this template will be up on the website early next week. So as Jason mentioned, VBP contractors may decide what intervention is most appropriate for the needs of their community. Interventions should be measurable and tracked. And I do want to communicate that the health department is really here to help any stakeholders who are looking for any guidance on what social determinant of health intervention to pick. So please feel forward to email, call, or request meetings with the department. We're very interested in helping guide the discussion on social determinants. So why are social determinants so beneficial? So there's unequivocal literature that reveals that the vast majority of premature mortality and morbidity rates are attributable to social, behavioral, and environmental factors. Nevertheless, the majority of spending on healthcare is largely targeted to medical determinants of health, while investments in key social determinants, such as housing and nutrition, dwarf in comparison. We know that investments in social determinants of health are extremely cost-effective and greatly improve healthcare outcomes. Some highlights of some successful social determinant of health projects include housing. Investments in housing to high-cost Medicaid members greatly reduce inpatient admissions and avoidable emergency room admissions. Investments in nutrition greatly reduce overall healthcare costs, and investments in the environment reduce school absences and missed work days, as well as asthma-related hospitalization. So as Jason mentioned, the VBP Social Determinant of Health Subcommittee created a intervention menu. So on Appendix C of the roadmap, there is an intervention menu that really provides a ton of information on key social determinant of health interventions. And both are available, both the subcommittee report and the intervention menu, or are available for download on the New York State VBP Resource Library. So one key intervention worth noting is New York's investment in the MRT Supportive Housing Program. New York has invested the most state-only money in housing since 2011 in the country, and we've really targeted our highest cost Medicaid members throughout the state and placed these members who are unstably housed or homeless into supportive housing. This program has been measured since its inception, and it has been extremely effective in reducing avoidable inpatient days, avoidable emergency department stays, as well as reducing inpatient rehab admissions and inpatient psych admissions. So I just wanted to give you a flavor of some very important social determinant interventions that are currently underway in the community and have been highly effective. So one example is what Empire is doing for its high-cost Medicaid members who are plan members who are homeless. They collaborated with the Bronx Health and Housing Consortium and moved their high-cost Medicaid members into housing. They used homeless and utilization data to narrow down what members would best fit. And I want to introduce Dr. Elizabeth Ouden, who we had the pleasure of meeting and videotaping, so she can describe the work that was done in Empire.
Apologies for the video not working. Not sure what happened there, but we will upload the video, which, as Liz mentioned, was is an opportunity to hear specifically about a plan contracting. So we will upload that, and along with the other video, which we'll skip that one as well. But I think it is interesting to hear directly from people who are addressing social determinants of health. And we'll definitely make that available. So Liz, do you want to take it away from there?
Sure. So as Jason mentioned, we apologize, but we will share both videos, and we also are going to create on the VBP website a special section for CBOs and social determinants. So all of the information provided today, as well as additional information and the videos, will be on the website to view after the webinar. So one of the important things that Dr. Ouden was mentioning is that after they identified their high-cost Medicaid members who were homeless, and over the course of 2 years, they placed these members into supportive housing. When that happened, they greatly saw tremendous decreases, 87% decrease in inpatient admissions in the first year, and an 80% decrease in inpatient admissions in the second year. They also demonstrated a 95% decrease in ER utilization for members that were housed in this program. They also experienced cost savings during both the pilot year and the full year of implementation. And an important note to make is that this housing was piloted before the behavioral health carve-in, so savings would have been much greater after the carve-in. But it's a wonderful video, and I encourage everyone to watch it so you can hear from Dr. Ouden herself on the implementation of that program. So another intervention we wanted to highlight was the importance of nutrition. And one entity in God's Love We Deliver is a New York City leading provider of medically tailored meals and nutrition counseling for individuals living with life-threatening illnesses in the city of New York. They deliver 1.7 million meals annually. 90% of their clients live below the poverty level, and 90% of their clients have more than one severe illness. They currently contract with managed long-term care providers, provide meals in the 5 boroughs of New York City, and they have registered dietitians on staff who tailor meals based on the client's medical conditions, dietary restrictions, risk of comorbidity, medication side effects, and common food allergies. We will post the video of Karen Pearl, who is the president and CEO of God's Love We Deliver. She can discuss the program that really is extremely beneficial to high-cost Medicaid members. But I think, you know, one of the most important facts that she points out is that nutrition is an inexpensive intervention, and that you can feed someone for half a year for the same cost as 1 day in the hospital. So the outcomes that God's Love We Deliver have pointed out is that it's a low-cost, high-impact intervention. This intervention is extremely successful in improving overall health and reducing avoidable healthcare costs. This intervention reduces avoidable hospitalizations as well as emergency room visits, and really increases the likelihood that individuals can stay in their own homes without moving to costly long-term care facilities. So community-based organizations, we also wanted to highlight some standards and guidelines in the roadmap for community-based organizations. So as mentioned, starting January 2018, VBP contractors in a level 2 or 3 arrangement must contract with at least one Tier 1 CBO. Language describing this standard must be included in the contract submission to count as an on-menu VBP arrangement. The state recommends utilizing CBOs because they really know the needs of their community and have been extremely successful in implementing social determinant of health interventions and supporting overall district goals. So if you are a CBO, what should you be doing now? One of the first things is really understanding your organization. If you're a Tier 1, 2, or 3 CBO, as Jason mentioned, a Tier 1 CBO is a nonprofit, non-Medicaid billing, community-based organization. And starting January 2018, Level 2 and 3 VBP arrangements must include a minimum of one Tier 1 CBO. Another important point to mention is determine how you will support your VBP arrangements across the state. We're going to go into a little bit more detail later, but really understand, would you like to contract directly or subcontract with a lead VBP contractor? Another important thing to start doing is engage PPSs to help identify other parties that may be interested in partnering with your organization, and assess your business model to understand the types of social determinants of health you may address and which VBP arrangements you may best support. So there are various resources for CBOs currently. There's CBO planning grants, and 2 current grantees are the Arthur Ashe Institute for Urban Planning and the Health and Welfare Council of Long Island. These are resources for CBOs to assist with investments as well as assistance with contracting. There are also our PPS innovation funds. So please contact PPSs throughout the state and within your region to really understand if there's any innovation fund opportunities. I'm now going to hand it over to Jason to discuss contracting requirements.
Right, and want to emphasize, thanks Liz, that we're going to be looking to post more resources out there. In fact, what I think one thing that might be helpful is for the PPSs, for the innovation funds that exist and the opportunities there. We can certainly gather that list of opportunities and post that to the website as well. We definitely want this website to be a place where CBOs can go for resources. We're also exploring the possibility of an online survey tool, using an online survey tool to actually have CBOs, Tier 1 CBOs, fill out some information, provide some information so that we can in turn basically build a statewide database of Tier 1 CBOs that we can share with plans and value-based payment contractors. So we definitely want to be active, and as Liz said, that if CBOs have questions and they want some assistance from the state, we're here ready to meet, to hear from you, to support you in your efforts as we move in this direction. So in terms of contracting, I think that one of the challenges that a lot of Tier 1 CBOs have expressed to us is that contracting with either plans or providers is something new. So in most cases, these organizations have relied on, as I said, philanthropy or local government grants or things like that to support their operations. They're not as familiar with signing contracts, and we've been certainly raising that concern with the plans and providers, suggesting that we really need them to try to keep things as simple and straightforward as possible. But I do think it's important, and I know that there's organizations, and this is obviously one of the key things with the planning grants, is to provide support to CBOs as they move into, in essence, potentially a new form of financing, a new form of support, but with that comes contracts. But as we said, that the interventions that we're looking to address with Tier 1 CBOs, our specific focus is for those VBP contractors that are in levels 2 or 3 arrangements. As I mentioned, about 34% of our 2015 contracts, managed care contracts with providers were level 2 or higher, or I'm sorry, were value-based. Most of those were level 2 or higher. Our experience is that once providers get into value-based payment arrangements, they generally move up to the higher levels pretty quickly. So we think there will be definitely opportunities for contracting for CBOs all across the state. So that's part of the reason why we're here, is that the plans and providers are going to be looking for partners, and we want to make sure that those partners are fully aware of what the opportunities are. So in these contracts, in these arrangements, as Liz had sort of talked to, they must include at least one social determinant of health intervention, and they must include at least one Tier 1 CBO. And that secondary requirement, it doesn't exist today, but it will begin in January of 2018, which is not that far away, less than 6 months away from now. So it's also why right now is a really good time, is that in order to get in compliance, plans and providers will that are in these level 2, including ones who are in existing level 2 arrangements or higher arrangements, will need to find ways to bring these Tier 1 CBOs into the fold if they're not already there. Tier 1 CBOs are not required to be organizations that implement the FTC, the social determinant of health intervention. But at the same time, we think that there's a key role that they can play given their experience in the communities. But there is a requirement that a CBO must be engaged in the overall effort of a value-based payment contractor. Also, level 2 and 3 contracts that do not include these, have not identified a social determinant of health, do not have a CBO or a CBO engaged, will not meet the definition, and that's important. They will not be considered VBP, and that's important because the plans face penalties from the state if they fail to migrate to value-based arrangements in a way that's consistent with what the federal government holds the state accountable to. And so the plans are very well aware of this, and that if there are targets for both level 2 and higher arrangements, as well as just overall the move to value-based payment. As I mentioned, it was our overall goal is 80%, but we do have a CMS requirement around level 2 or higher, which I believe is 35%. Yes, 35%. So as a result, in order to move contracts into that and meet that requirement, the plans are actively going to have to engage CBOs, and contracts will have to be signed. And that, as I said, MCOs that do not meet the VBP objectives, the goals, the targets, will see those penalties. And I think it's important to point out, when we've looked at the current state, and at least as it was, say, in 2015, and we're in the midst of finalizing the 2016 survey, we see variation across the state. We see more VBP contracting in, say, New York City than we do in, say, Western New York. So I think there's a lot of opportunities all across the state for this type of contracting to occur, particularly in places like Western New York, where there's hasn't been as much value-based payment contracting to date, and we expect it to begin in earnest here in the coming months. Okay. All right, so in terms of CBO contracting strategy, just to give it, we definitely see the sort of 2 primary routes for contracts to be executed. One is with the MCO itself. MCOs have that option. They can contract with a single community-based organization, either on behalf of a single VBP arrangement, or an MCO could contract with a CBO to support multiple value-based payment contracts. So we know we have CBOs of different size across the state, and some actually serve a fairly large geography. So in certain cases, it may make sense for the CBO to contract with, or the MCO to contract with a community-based organization to support multiple VBP contractors in their network. So that's one path, is the MCO contracts directly with the CBO. The second is that the contract is actually between the VBP contractor and the community-based organization. And I also want to emphasize, for those maybe a little less familiar with VBP overall, when we say VBP contractor, we mean it could be a hospital, system, provider, a single organization, or it could be an IPA, or it could be an ACO. We allow for the VBP contractor to take multiple forms. They have to be in compliance with state laws relative to contracting. So for instance, a performing provider system cannot actually contract for the direct provision of healthcare services. If they want to do that, they must become either an IPA or an ACO. But you have obviously large integrated systems, often hospital-led systems. You also have a large number of IPAs all across the state and ACOs. Typically, those are the kinds of organizations who will be in those level 2 or higher arrangements. But it isn't limited there. We can and we expect to see some larger clinics, for instance, also interested in multi-practice clinics, and even some larger FQHCs could decide to go into, say, a level 2 arrangement, particularly focused on their chronically ill patients. And in any of those circumstances, regardless of who the VBP contractor is, these requirements apply to them. Also want to emphasize that regardless of which path you go, whether it's contracting with whether it's the CBO contracting with the managed care organization or the CBO contracting through the VBP contractor, CBOs are not required to take risk. And I think that's sometimes been a little bit of a misunderstood point. It's not to say that a CBO can't take some risk. And for instance, a level 1 upside arrangement where you get a bonus payment if the CBO is successful, we fully anticipate that probably will be a common element of these contracts, but we do not at the state require it. It could be as simple as a services contract between an MCO or VBP contractor and the CBO to provide a specific set of services with some contractual performance expectations. I do want to emphasize to the CBOs who are on this or listening to this presentation, CBOs should expect performance requirements to be included in each and every contract. CBOs will, in fact, need to perform if they want and they expect these contracts to continue. Whether it's the MCO or the VBP contractor that you're contracting with, they will be facing financial implications if they are unsuccessful. So this is not about effort. It is not about doing nice things. This is about achieving the goals of the value-based payment effort, which is lower costs and better outcomes for Medicaid members. And CBOs need to understand that it will be expected that they will perform and help in supporting and achieving the objectives of the MCO and the VBP contractor. So in also just some other contracting requirements, and this is somewhat a restate of what you see in the roadmap, but inclusion of at least one Tier 1 CBO, just in terms of some specific requirements. Contracts must be submitted with a complete DOH 4255 form, contract statement, and certification. This is required whether the CBO is contracted with the MCO or the VBP contractor. And so it's just, we certainly more than willing to make that form available on our website so that you are fully apprised of what that is. You'll see in that section C of the form, the CBO should be manually identified in the area designated as other. And want to emphasize this is a form that's very familiar to our Medicaid managed care plans. So to a great extent, it's really up to them to submit this paperwork, but we do want the CBOs to understand what some of those requirements are. Submitted contracts must be in compliance with all of the provider contract guidelines. Those were updated in April of 2017. And we can provide that information, those guidelines out for folks as well. And then in instances where the CBO is contracted with a VBP contractor as opposed to the MCO still must submit the agreement between the VBP contractor and the CBO to the state. So as we said, that is a pathway here, but we want to continue to track this type of activity. And so we're going to be expecting that contract will be submitted to the state so we can stay on top of this. And in terms of requirements, and specifically around the social determinants of health, all contracts submitted for review must include what that social determinant intervention is and use a specific template for that purpose. Contractors that do not include the template will not be approved. This is just some of the mechanisms we have in place to help ensure that these requirements are in fact complied with. We take that role and responsibility very seriously. And the template is a report explaining a measurable reason why the SDH was selected and identifies metrics that will be used to track its success. So we definitely want this to be thoughtful. We do not want simply to sort of say, well, nutrition, but not to have done an analysis of why lack of access to nutritional food is a problem for the top population. We do want the plan, the provider, and the CBO to have a collective conversation about what the needs are of the community and what is the right intervention that should be done to address the need of that particular population. I also want to emphasize that we do see, and for those maybe a little less familiar with the roadmap, we see value-based payment contracting can be done for what we call total cost general population type arrangements, meaning that a provider sees a large and diverse set of patients and they contract in a value-based way across that entire population. We also see arrangements that could be focused on specific subpopulations, say, for instance, specialized providers who serve folks with patients with AIDS, HIV would be one example, or patients that, or providers that serve, say, the developmentally disabled, where they will specifically focus on that subpopulation. But then we also see value-based payment arrangements that aren't for a full set of services and take on risk associated with the full cost, but are more focused on a subset of services. So one is an example of that is integrated primary care. That's really targeted at primary care providers, including pediatricians, who really want to focus on the subset of their population who have a chronic illness, and there's a risk arrangement there where they look at the cost for their chronically ill population that allows them to hopefully really focus on improving the health of that population. But also another example could be a set of services, for instance, maternity care. We're very interested in a bundled payment that could be level 2 or higher, specifically in maternity care. So it doesn't always, value-based payment isn't always about a general population and a total cost needs. We do have, and we anticipate having some providers that are very focused on a subset of the population or a subset of services. All right. So just a few final thoughts in terms of moving forward, and we're very excited, once to have this opportunity. But we wanted to just highlight and point to just a few statements that are actually in the roadmap. And actually, as I said, really encourage you, for those CBO organizations who are interested in contracting, using this as an opportunity to expand your services, use this as an opportunity to better serve your communities as CBOs. We definitely encourage you to read the roadmap, to participate in the VBP University, which really is an opportunity for us to sort of take that, can be fairly dense documents, like roughly 70, 80 pages in length these days, and break it up into a little bit more digestible pieces, but just to highlight a few things that are specifically stated in there. Statement number 1 is to create a process which would include an independent retrospective review of the role of the CBO, to determine if the VBP providers are adequately leveraging community-based resources. So it's important that we really do want to see whether or not these interventions are successful, and we need to be able to track that effectively. Also, we want to evaluate the feasibility of incorporating social determinant of health measures into CORE. So there's been a lot of interest in moving away from mostly health process-based measures, the sort of HEDIS type measures, to adopt other measures for the population. We've done that and looked at that already, particularly in things like the creation of the HARP program, Health Recovery Plans, a very unique Medicaid managed care product for people with significant behavioral health needs. We're the only state in the country that offers that kind of specialized managed care product. So we are pushing the envelope here, but we want to, as we learn more about the interventions here, to begin to look at including measures that are plan-specific measures that are tied back to the social determinants. We'll also be monitoring progress on the prevention agenda targets. We have already directed through district PPSs to be active working on specific prevention agenda items. Those are what we call the Domain 4 projects, and so PPSs are engaged there, but we'll also be monitoring that across the state and potentially looking to provide greater direction, maybe even standards, requirements in terms of VBP contractors to really address some of those prevention agenda targets. The state intends to introduce a dedicated value-based payment arrangement for pilot purposes in 2018 to focus specifically on addressing the prevention agenda target. So it's something that we're going to be looking at potentially as part of the next budget for consideration. We don't know what that the fiscal and financial environment is going to look like, but that is something that we will be looking at as well. Definitely, this, as I say, is something where we feel strongly. We think it's a great opportunity, but it also is an area where there's much to learn. But as we learn more, and it's something that we're in for the long haul, not in for short, quick wins. We want to build these relationships. We know many cases the relationships flat out don't exist today. Some of the interventions that folks are going to want to try maybe haven't been tried on the scale that they've needed to be. Some of these providers, these CBOs, have never been in contracts or in contractual relationships of these type in the past. So there's a lot of new here, but we'll learn from it. Not every single intervention that is tried will be successful. We are fully aware of that. So we just need to learn and adapt. And one of the benefits of VBP in New York is that our roadmap is going to be updated every year. So it's an opportunity for us in consultation with our diverse stakeholders to get feedback and update that plan based on our experiences in terms of as we move forward. So just in terms of next steps, in terms of the roadmap, as I say, we will continue to look to update that, but it's important for folks to know what those requirements are, and we certainly talk to the provider community all the time about that, and to the plans as well, about what those level 2 and 3 requirements are. But they must have identified and this is something they should all be working on now, is in order to be compliant, is to have identified a social alternative health intervention that they want to do, and by effect starting for all agreements that are level 2 or higher, they must have a CBO engaged, a tier 1 CBO engaged by January of 2018. So there's a decent amount of work already out there that needs to get done, and we're hoping this will really kick off even more discussions all across the state. Next, the state is open to any feedback regarding social determinant health interventions. As we said, we have a lot to learn, and we want to learn from the community of providers and organizations that are going to be out there in the field doing it. We'll also be scanning the nation. In fact, we'll be scanning the world for best practices and ideas, and as we see any new ideas, we're more than happy to share them with the field. The state is open to feedback and ideas, and please feel free to contact us. We got a number of questions in advance of this. We'll try to address as many of those today in the session as we can, but also we are going to be preparing a Q&A document specifically on this topic that we will post to the website so that not only will you have access to this webinar and to the roadmap and to information through VBP University and all the other supplemental documents, we'll also have a Q&A that will be a living document that we will update as we go forward. Also, in terms of DOH, as I mentioned, the VBP University, which we're very excited about, we've gotten tremendous positive feedback on it. Folks are found the first module very useful, and as I said, the second module just went live yesterday. But we did VBP boot camps last year. I want to promote those for the second year in a row. We're going to have these boot camps, and we will include a session each boot camp on this important topic. So definitely want to encourage anyone listening to this to look at that list of opportunities and attend one of them that's in your area. We also are thinking about a specific website. Well, we'll have a page. We're also thinking about a website dedicated specifically to Tier 1 CBOs. We had roughly 1,500 people sign up for this webinar through yesterday. a lot of folks. Not sure how many are on at the moment, but yeah, a lot of interest in this topic. So we think that we're definitely going to focus on trying to get more information out, particularly targeting the CBOs. As I said, we're going to be working on a specific module for VBP University that targets this group to raise awareness, answer questions, and provide resources. And as I mentioned earlier, we will be releasing an FAQ specifically on this topic that will be reflective of all the questions we received so far. I think there are about 20 that we received in advance of the session, and then any others that continue to trickle in. We definitely want to make sure that all parties are fully apprised of the requirements, as well as the opportunities that are presented with this important initiative. So here are links and opportunities for folks. And as I said already, what is out there, you can find the university series, the boot camp listings in terms of locations and times. These are the boot camps are all-day sessions, and also out there you'll see that last year's boot camp I think is still posted. We recorded actually last year's boot camps were 3 full-day sessions that we had, and the video for those 3 full-day sessions are available on the website. So those who really want to dive in deep, there's plenty of video to watch over the holiday weekend. And then the roadmap itself, as I said, very important governing document. I think it's useful. It really is what we always go back to. What does the roadmap say? We have to be in compliance with it. CMS holds us accountable to it and asks us about how we're doing relative to it all the time. So it's really important that folks really fully understand that. And the value-based payment for providers, video 1, what was this? I'm sorry, which video? It's the Simply Does It. Oh, Simply Does It video. Oh, yes, yes. So, but there's a video that available there as well, and hope that folks find that as a resource. All right, so in terms of feedback or ideas, if you want to reach out to us, here are a couple emails specifically that can be reached. The first one is just your general ideas, questions, feedback. Send that to our supportive housing, sort of more our general sort of email we've been using around social determinants of health. But if you have specific questions around contracting, please use this email. It's our sort of helpline for providers and plans relative to contracting. So if you have specific questions about that component of this, please use that email address. So that's it. What we'd now like to do is the time remaining, which is, I don't know, probably about 50 minutes. Open it up to questions from the field. And I don't know if there's anything else we need to say about the questions. And just give us a minute here. We're going to put you on mute as we reopen the questions component. I will read those questions, and I'll read those questions and then attempt to answer them the best we can. So hold on as we get that set up. All right, folks, welcome back. And we're going to start with the questions that were presented online, and thank everyone for answering these questions. We'll try to get to as many as we can. So first and foremost, what is meant by supportive housing? Is there a counselor that lives in the building, addiction services, a clinic co-located in the housing structure? Good question. Supportive housing, we actually do not and have not used a formal definition of it. Generally, when we think of supportive housing, we think of housing that provides sort of wraparound services, that's affordable, but we have not had a formal definition of it, and partly because what is supportive housing can vary depending on the subpopulation. But we have not, but it's something that we certainly can look at in the future if that's helpful to the field, to provide a little bit more specificity in terms of what is supportive housing. We can also check in with our colleagues at OMH and OASIS who do contracting and see if, to a great extent, do they have a more formalized definition of it. But at least we have applied a more flexible definition as we've been operating our MRT supportive housing. What was the program? Was the program a housing first model or transitional housing model? A question that was also presented. I think what you're referring to is our supportive housing program itself. And also, Liz, if you want to address that.
Sure. So we really have a mix of different models because we serve a diverse MRT population. So one of our models is Housing First, our OASIS program that really targeted high-cost Medicaid members with substance use issues. We also do provide transitional housing. DSRIP is one good example. The Finger Lakes has a transitional housing model that they use. But I will say that we provide various models depending upon population needs.
Right, and I think a key emphasis, and this dates back to the beginning of MRT, we are an evidence-based organization. We want to apply policy changes that are evidence-based to the maximum degree we can. We have not shied away from things like Housing First or harm reduction or things. In fact, we just, after multiple years of trying to get CMS approval, we finally got CMS approval for a state plan amendment to expand services to include harm reduction, which we're very excited about. So as I said, we are always interested in new ideas, new ways to meet the needs of the community that will lower costs and improve outcomes. And as I say, if the data shows it works, we're interested in it. Next up is how much was the investment and by whom for social determinants of health example 1? They mentioned the reduction for the 4 patients but what was the cost to house them?
Sure. So in example number 1, this was the Empire example. They worked collaboratively with the Bronx Health and Housing Consortium, but they also utilized one of our MRT health home subsidy programs where individuals who are eligible for health home and homeless, we provided a pilot where we provided the rental subsidy for individuals who are eligible. So I think that was really the funding source identified for the rental subsidies that Empire used.
All right. Next up is, will these slides be available? The answer is yes. We will be posting this webinar and the slides will be available to any and all. Can an entity that has many separate programs, including Medicaid funded services and non-Medicaid funded services, use its non-Medicaid funded programs as a level 1 CBO? So it's a question about our goal and with a level 1 CBOs is not to have a Medicaid billing provider create some subsidiary that then allows them to contract. We really are looking at true CBOs that are level 1, meaning that they are not a billing provider. There's plenty of opportunities for billing providers to be able to participate in value-based payment contracts directly as providers. So we really are, and if that needs greater clarity out to the field in terms of the definition, we're happy to provide it. But we definitely are not interested in sort of say a for-profit LICSA spinning off a organization to serve as a level 1 CBO. That is definitely not our intent. Next question is, could you please keep the slide a little longer to follow the conversation? Sorry.
Yes, so what we
that.
will do is we will post everything on the website so everyone can look at the slides, and I think a audio or a video of the deck will also be available online.
Next question is, I feel like this is pushing agencies like ours to spin off the non-Medicaid SDH parts of our business as a separate legal entity. That is pretty backwards incentive. Right now, we can pretty easily share client data. If we spin off these entities, service delivery information will be harder to measure. We are certainly not trying to encourage. Really what we're trying to do is create contracting opportunities for tier one agencies who otherwise have these opportunities and may get left behind. Entities that are Medicaid billing entities, entities that are maybe not tier one, we think there's opportunities. In fact, there's no prohibition on contractual relationships between providers who aren't tier one CBOs. In fact, as I mentioned earlier, we're expecting there to be a contract with a tier one CBO, but in fact, we don't even say that tier one CBO has to be the entity that addresses and supports the entire social determinant of health intervention. Definitely an opportunity for the contractor or the plan to work with a provider that has a lot of expertise and knowledge and experience in particularly addressing social determinants of health, may have a really successful program that's relevant to be expanded to the population. There's something that prohibits that. What we're really trying to do here is to create an opportunity for these organizations that have not traditionally provided services in the Medicaid population to become part and parcel of the program. So we are not trying to encourage that spinning off. Next up is a question is, how do we contract for a meeting or help? How do we contact for a meeting or help? Please use the email that was mentioned, the supportive housing email. That would be the best way to email us if you are interested in getting on the phone with us to get your questions answered. So encourage you to do that. Thanks, Kim. Next up is, if a CBO has multiple programs, one of which is reimbursed by Medicaid, but all others aren't, can it be a tier one? That's the same question I had gotten earlier. Thank you, Lisa. So the answer is that we are trying, and maybe what we can do is provide greater clarity on this in terms of who a tier one CBO is, but we really are trying to identify those organizations that aren't part of some broader umbrella that have, in essence, you know, a key element of it that is as a Medicaid billing entity. You know, I think that the concern here is that you would go down a slippery slope where you could have large hospitals that could say, well, we have a program that is addresses social determinant. Maybe it's offered by an affiliated entity that's a not-for-profit, and so I think what we're clearly trying to do here is to create contracting opportunities for true tier one CBOs. Many of these organizations exist all across the state. A lot of them are led by individuals in the community. They are culturally competent. They're linguistically competent. That is really who we are interested in trying to get into the contracting fold with this effort. Okay, so next question is a question about familiarity of the VBP levels. Can you explain what that refers to? So good question. Encourage you to participate in VBP University. Our first semester focuses exactly on that topic and such, but just to give you a quick explanation, level one arrangement is what we call upside only. This is where a provider, if they're successful in lowering costs, improving outcomes, and they generate shared savings, meaning that the total cost for the population of the services they provided comes in a little bit under what was negotiated, they can capture a portion of that shared savings, maybe as much as 40% of that shared savings. If they are unsuccessful in level one arrangement, there's no consequence to them. Level one always sounds very attractive to providers when they first hear about it. Why? Because if they're successful, they see a financial gain. If they're unsuccessful, there's no consequence. However, there is in level one arrangements, because the plan holds the downside risk, that most of the shared savings, if successful, goes back to the plan or stays with the plan. Level 2 arrangements are ones where the provider begins to take on downside risk, meaning if costs exceed the negotiated amount, there's a financial consequence to the provider. Now, that financial consequence could take the form of a future rate reduction. It could take the form of a withhold that's not returned, or it could take the form of a check actually being cut by the provider to the plan to cover whatever was agreed to as the potential loss. And so multiple ways to do that, but the benefit to the provider in a level 2 arrangement is that they get to capture the vast majority, 90+% of the shared savings if they're successful. Now, there are opportunities to limit downside risk in a level 2 arrangement, so you don't have to go in without any training wheels, so to speak, but that's what level 2 is. Level 3 is prospective payment. It is really breaking out a fee-for-service, because in both level 1 and level 2, the provider is billing using the traditional fee-for-service system, but there is a global budget and a calculation that's done after the fact that looks at total cost of care. But in level 3 is when you get out of that the fee-for-service billing and you translate what is this global budget usually into payments to the provider on a monthly basis. Creates a much more even revenue stream, much greater predictability, and with that, maximum flexibility. No longer do you have to find a billing code to bill for a service. We really think at the ultimate, at the end of the day, that will lead to the greatest opportunity for innovation, creativity, and really patient-centered delivery, is when we get to that prospective payment and we get out of this system of trying to find some HCPCS or CPT code to bill for services. Also, what comes with that is the opportunity to end the mother may I process of utilization management, when providers have to ask a plan for whether they can provide a service to a person or not, prior authorization, all these payments. Next question is, I also feel that a lot of social determinant of health providers in our region do provide some Medicaid services in our region, especially given the push for HCBS bringing more agencies into Medicaid. It's very possible that for some needs in our region, there are no non-Medicaid CBOs. Great point to raise. It's also one of the things that I think would be helpful for us is to do this tier 1 inventory to see what tier 1 providers are available in communities all across the state. If for whatever reason we do have a part of the state where we don't have providers, sort of two options. One, maybe a provider who's serving in an adjacent area might be willing to expand, or if necessary, and it, obviously if it's a requirement that can't be met, we will look at that on a case-by-case basis or a region-by-region basis to see if we need to modify that requirement on a go-forward basis. But it is something we will monitor, and thank you for raising that point. Next is, can you please clarify where we can find the social determinants of health intervention menu and Excel spreadsheet that is referenced? That link in the report found in the VBP section of the DOH website doesn't appear to be live. Thank you. We will check that and get that back out to make sure that, and we'll send that out to the email listserv with make sure that you get all the materials from today. But thank you, Joanne, for pointing that out. Next up is slide 29. States that the CBO does not have to perform the SDH. Can you clarify how this would work in practice? Would the MCO do the SDH work itself? Good question, good point. And it's sort of what I got to a little bit ago. We do want to engage tier 1 CBOs. We want contracts to be signed. But for instance, let's say in the first year, a CBO could be gearing up, could be staffing up, and it may be a period where the CBO isn't quite ready to engage, but there's a need for a contract to be in place. You could meet that contract requirement and even have the CBO not yet online providing direct service, but that would not waive the requirement on the MCO and the VBP contractor to address that social determinant. They may have to address it in other ways. We do think the most common use of contracting will be to address an SDH, there isn't just a hard requirement that is in place around it. This also gives the opportunity to use CBOs. For instance, you could have an joint effort between a tier 1 CBO and a higher tiered CBO, one that does do Medicaid billing, that could be, maybe a way to help support that tier 1 CBO in expanding its capacity, and maybe a joint partnership between a single CBO and another organization, maybe a large organization who has experience billing Medicaid, to address it. The last example that I could sort of think of at the top of my head is you could have a tier 1 CBO in a part of, let's say, for instance, you have a larger population. You could have a tier 1 CBO address the social determinant for a subset of that broader population, but then have other organizations address the remainder of that population as part of a more comprehensive effort to address the social determinant of health. But all those, I think, are reasonable options that explain why those concepts, in essence, are separable. Further, our IPA member agencies all are CBO/SDH agencies of some kind. The entire idea of an IPA was to reduce the need for separate contracts. Understand the value of IPAs. That said, we definitely think that now there's nothing that prohibits a tier 1 CBO from joining an IPA. Happy to have chats if that's the case. We didn't think that would be a common occurrence, but certainly is something that we can look at and think about. But definitely we're anticipating that if it's an IPA going into a value-based arrangement, that they will in fact contract with a tier 1 CBO, because we definitely want that cultural competence. We want that that kind of community connection to be brought to the fore. Next up is I'm with the Children's Aid Society. We are both a CBO and a medical provider. We have community-based, school-based health, but also run early childhood and such. Could our partnership referral system between our health center and our early childhood programs, for example, be considered an intervention? Certainly, it's an intervention. As I say, they are not linked. We would expect there to still be contracts with there's still a requirement for this tier 1 CBO contract, but there is absolutely no prohibition on any organization, including one such as yourself, is being part of the social determinant of health intervention. So just want to emphasize that. Next up is a question from Matthew. Can the DOH provide a contact person for a provider who is attempting to contract with their PPS and has been denied? I think the best way to do that is to send us an email through the supportive housing email, and we're happy to look into that, Matthew. Next up is also, could you please clarify whether rates have been set for specific SDHs, or would that be negotiated amongst the parties? The answer is there are no specific rates. This would be entirely negotiated between the parties. Next up is Janet. CBOs will probably be very challenged to meet New York State requirements for data security for handling PHI. Is the New York State planning to set up a complaint environment that CBOs can use to exchange, or a compliant environment for CBOs that can use exchange? Information sharing, definitely a challenging environment. PPS is right now working very hard to solve a lot of those challenges. We're working with them on that. That said, we aren't anticipating anything new and special in terms of information sharing. We're certainly looking to the PPSs in consultation and work with their RIOs to really address a lot of those challenges, and then leverage those solutions to support their CBOs and VBP contractors. A major focus of the PPS is to support the move to VBP, so we think they're logical as opposed to creating something brand new. That said, we definitely think there are interventions that CBOs can do that don't include the sharing of PHI, and so want to definitely encourage folks to think about that. But if you have further questions, happy to problem solve with you on that. Question, is that the most recent roadmap? The answer is the one that's up on the website is the most recent one. Next one up is from Pamela. Will slides be emailed? Will they be emailed to participants in today's thing? Is that correct?
Yes.
Yes.
We'll email it on the MRT listserv.
Well, okay, so it will be emailed to the email listserv, not to the people who signed up for this. Is that correct?
We could do both.
Oh, we could do both. All right, we will do both. We will send it to both the folks who participated in this as well as out to the email listserv. Next up is, where is the best place to submit feedback on ideas? Once again, submit those ideas or questions to and feedback through the supportive housing email mentioned earlier. And up on the website right in front of you, I was saying. Next is, how do local CBOs know what providers in our area are level 1, 2, or 3? Very good question, Susan. That's why we are going to do this online survey. More information will come out via the MRT listserv, but we're definitely going to want to create a statewide database of those tier 1s, and we will then share that with the field so folks know who they should contact with. Next up is, will you be emailing the deck to all participants? Yes, we will. Next up is, how do we know who the VBP contractors are? So VBP contractors will take multiple forms. I think that probably the best way to go about this, if you're a CBO, is to either connect with the plan, who will be working to identify and work with different groups of providers who will be forming different types of VBP arrangements. But I think one thing we could possibly do, Susan, based on your suggestion, is maybe we could think about ourselves is, as these things begin to shake out, and we have, because a lot of these contracts are submitted to us, we could actually potentially create a statewide database of people who are providers or groups of providers who are in level 2 or higher arrangements, which, because those contracts are submitted to the state and approved. So perhaps that's something we could do on our end. Next up is, do providers that provide Medicaid services and who also provide tier 1 Medicaid services have to enter in a contract with another CBO? So the answer is that you have to have a contract plan, or VBP contractor must contract with a tier 1 CBO that meets the tier 1 definition, but it is free to utilize other organizations, other CBOs to address the actual social determinant. We do think that this is a great opportunity for the larger CBOs, that particularly ones who do Medicaid billing, to partner with and support tier 1 organizations. I think that could be a wonderful outcome of this, is support in those efforts. Next up is, CBOs not required to be organizations that implement the SDH. Clearly that's creating some questions. Are you implying the VBP contractor may be addressing a specific SDH concern, and the CBO is addressing a separate? So as I'd mentioned earlier, we definitely anticipate that in most cases the tier 1 CBO will be working on a social determinant. We just don't make an absolute requirement. I gave you a couple examples about why that might make sense. Next is, how does the local Department of Social Services relate to VBP? Definitely, we see that there are opportunity, partly as a provider, because in some cases you are a Medicaid provider. We're definitely hoping you will be part and parcel of VBP arrangements, but you definitely are an essential resource that CBOs and value-based payment contractors and plans should connect with. And we're always open to ideas to strengthen those connections. Next up is, does the state currently have a process to review and approve VBP contracts prior? Yes. So we have specific requirements around what kinds of contracts have to be submitted to the state and approved. So yes, we will be, and as I mentioned earlier, we will be tracking this very closely. And plans will be required when they submit contracts for approval to include this information. So we will be maintaining oversight. Okay, it says, please put the contact email back up. Thank you. I think it should be up. Is that correct? Is that?
It might be blocked.
We also,
it'll also be in the email.
Just in the contract would be a separate email address on slide 31. So all those, we'll provide all the email addresses at the end of the webinar.
Okay, so we'll send out to everyone on this email the right contact information on the various topics. So that's a good ask. Next up is, can you get more bonus points for addressing more than one social determinant? The answer to that question is no, there aren't any bonus points. There aren't any points in general with this. But certainly we believe at the end of the day that as you move to value-based payment, you have already a built-in incentive to address social determinants. And if you do, and obviously, as Liz mentioned, there's some really good examples of how that can help you lower costs and improve outcomes. That's what VBP is all about. So we definitely think there will be providers, plans addressing it. We wanted to create a floor, create some momentum, and create a real incentive to make sure that those tier 1 CBOs were engaged and as part of this. What are a CBO that provides family planning services? As such, we bill Medicaid. Does this mean we are not a tier 1? The answer is yes. If you are billing the Medicaid program, you are not a tier 1 CBO. Next up is, are there specific constraints on the amount of level 1 bonus money, and may we subcontract this as a cost component of TCGP? The answer is yes. I mean, there are no limits, no constraints, and you certainly can contract it as a component of your total cost general population arrangement. Next, can you clarify a bit more on the SDH intervention template? I'd love to see an example of what an ideal document would look like. Good question, Kimberly. We will make sure that that document is made available. We'll put it up on the website or just send it out, but yes, definitely we will do that. Next up is, will there be additional outreach provided to behavioral health organizations? Absolutely, as part of this. In fact, our colleagues at OMH have been doing just that. In fact, they have some reinvestment funds from previous MRT efforts that they are investing directly into behavioral health providers to support them in their efforts to move to value-based payment. So I want to emphasize that this is not the only opportunity. I know many organizations feel that, and they are community-based organizations, but they do bill Medicaid. There is, particularly for those who are in the behavioral health space, there is a explicit opportunity to receive support, and it's OMH and OASIS are engaged in that. We certainly can raise awareness for those or connect you with those resources if you're not already participating. Next up is, are there constraints in the amount of level 2 or 3 seed money, and maybe we subtract them as costs? Well, there are no constraints to that. We try to give providers and plans a lot of flexibility in terms of how much risk wants to be transferred and such. Next up is there a single CBO entity that has both a program that is billable yet additional? This is back to the same question about what is a tier 1 CBO and what about if it's billing. I think what I'm getting the flavor of is we probably want to put out to this broader group a very clear definition of what constitutes a level 1 or I'm sorry, tier 1 CBO. As I said, our goal is not to have a large organization that bills Medicaid create a subsidiary for the purposes of trying to get into these contracts. The purpose of this is to get tier 1 CBOs, organizations that traditionally wouldn't be maybe were left behind in an effort like this, explicitly contracted with. It also is not in any way a limiter in terms of who can contract with. We just wanted to have a specific requirement to get these tier 1 CBOs into the mix because we think there's a lot to be offered there and we don't want them to be left behind. Next up is, how can home care agency participate with the CBOs or COBs? I think that meant CBOs. Home care is a very important service. It's fast growing. There's more home care services being provided through Medicaid today than ever before. Happy to connect and have a conversation, particularly around managed long-term care. But definitely we see that as a provider, tremendous opportunities, whether that's supporting people transitioning out of hospitals, moving people out of nursing homes back into the community. Lots of opportunities for home care agencies. Next question is, we are a tier 3 CBO. When do come to this? Do we wait for a contract with MCO? So no, there's nothing that limits, as I say, any kind of CBO, whether you're a tier 1 or a tier 3 from participating. We just don't have a hard requirement in the case of, like we do with tier 1, that they must be contracted with to address social determinant. But there is nothing that prohibits the plan, the VBP contractor, from contracting with any entity that can help them address the social determinant that they're required to identify. Could VBP contractors support their local health department or other CBOs to implement local community health improvement plans tied to French agenda? Thank you, Sylvia Pirani, our fellow Department of Health colleague. Absolutely. We definitely see VBP contractors as agents for addressing community health, improving community health, and tied directly to the prevention agenda. We mentioned it earlier in one of the slides. Definitely think that that's an opportunity. In fact, that is something we want to encourage, and we identify some best practices. We'll want to highlight those. Is the contracting diagram, or in the contracting diagram, will an MSO, I think MCO, be a contracting entity? So the answer is yes, they will be contracting, but we also give the opportunity for the VBP contractor to also contract with the tier 1 CBO. Next is post-district. Is there a plan to compensate tier 1 CBOs down the road through Medicaid? Not sure if we have a vehicle to do that. Definitely one of the ways we want to get tier 1s included is what we're talking about here today, is to get them into contractual relationships, and in a value-based payment context, that really becomes the way that they can get compensated for the work they do. Next is many CBOs will need some capacity building resources to effectively conduct contracted supported services. Will or does VBP payments, MCOs consider funding this fees and such? The answer is that we will, that's part of the reason why we have been contracting with these support contractors to support VBP or CBOs in this effort. We know that there's a need for capacity building, but also I think was mentioned is we do anticipate that plans and providers will provide upfront funding, adjust the compensation because a lot of these CBOs do not have the sort of capacity to staff up without resources. So that's definitely anticipated, but that's why we have these contractors is to really provide that support as we move to VBP. Next is where might certified home health agencies provide home contract and define their ability to contract with VBP MCOs directly. Obviously, almost all of our home care services now are in managed care, and basically encourage you to work with the MCOs you're currently contracting with and talk to them about what you can do to support their VBP requirements. Next up is, does OMH supported housing qualify as tier 1 CBO, or does it have to be an MRT supported housing? So the question is, does supportive housing that receives payments from OMH, does that disqualify you? Basically those payments that you receive, like for rental subsidies and whatever, generally is not Medicaid funds, but it's something we could take back. But I think what this gets at is just this broader question of making sure we clearly define for everyone what constitutes a tier 1 CBO. And one question I think that you're getting at is, if you are contracted with the state to be a supportive housing provider, does that disqualify you from being a tier 1? And the answer off the top of my head, I don't know. We'll have to take a look at that. CBOs you refer to are not covered services under MLTC. If there is a contract, does that imply we will reimburse for that service? The answer is that all PPS, all providers are required, all plans, I should say, MCOs, regardless of type, are required to meet these requirements if they're in a level 2 or higher arrangement. We anticipate most MLTCs will be, at least initially, in level 1 arrangements per the roadmap. However, there is the opportunity, and there's no prohibition, and we're talking more and more about what we could do to think about level 2 arrangements. But there are certainly vehicles for that. If they do go to a level 2 or higher arrangement, then this requirement does apply, and that the expectation for a contract would apply. Next up is the housing intervention had an outcome study, N of 4, would like to qualify for SDH/CBO outcomes like this will pass New York State scrutiny. I'm a little confused by that question. But yes, it was a small study. I think we wanted to highlight it in the fact that this was a plan that was contracting and had seen enough value that they wanted to begin to look at housing as an option within the service array. It's a practice we want to encourage. That's why we highlighted it. But there's certainly other housing studies. Liz mentioned some of the stats from supportive housing program that we at Medicaid offer, but there's also other results from the myriad of other supportive housing programs funded by other agencies as well. Next up is in the Bronx, we have been able to track and show major savings for people housed through MRT supportive housing pilot programs. So that's great. We continue to identify high utilizers who benefit from supportive housing but do not meet the New York criteria. Why was the pilot program not expanded?
It was really just resource limitations, but I think as we look at the success of the programs and build our executive budget for next year, we're always looking to expand when we have resources available.
All right, next up is if there are prevention agenda targets which are not included as any of the regional PPS projects, what is the opportunity for CBOs to support these efforts in the community with VBP funding? So bottom line is that, yes, that's true that PPS has got to select their projects, but there's nothing that prohibits the plan, VBP contractor, and the CBO from addressing other things identified in the prevention agenda. It's really going to be up to those organizations to decide what they want to address based on the community needs. We are CBO and our MCO carriers have not approached us on this. It's the responsibility of us to engage. We do belong to an ACO. Well, you are already on your way, the fact that you're in an ACO. What we anticipate now is, that's part of one of our goals here was to really kick off these discussions. Reach out to us through the email, the supportive housing email. Happy to sit down with you and better understand your unique situation. But we're definitely hoping that as a result of this and the guidance that's coming out, that we'll get even more MCO activity. Our MCOs receiving additional funding or incentives from New York State, they're specifically tied to the CBO inclusion requirement. The answer is no. We are not including any funds. May consider and may add funds in the future, but at this point, it's just an obligation that they're expected to meet out of their existing capitation payments. Could a model be that an MCO has a contract with one CBO, however, have another CBO under that one CBO that will help address the SDOH under that one contract? The answer is yes. There's quite, I think, a lot of flexibility in terms of contracting and tiering of contracts and multiple organizations being involved. Have VBP level 1 CBOs identified anywhere? That was what I mentioned earlier. Is definitely we will be doing a survey and ask the CBOs to tier 1 CBOs to self-identify and then provide that information to the field. Will this tier 1 CBO contract starting January 1 of 2018 be between the qualifying CBO and the PPS MCO such? As I mentioned in the presentation, the contract will be between the CBO and either a plan, an MCO, meaning an MCO, or between the CBO and the VBP contractor, which could take any one of a number of forms. It will not be with a PPS in the sense that a PPS must become either an IPA or an ACO if it actually wants a contract for the provision of services. But that is possible, and we know that there are some PPSs who are going in that regard. I come from a billing provider that is not holding a primary care patient. PPSs want to consider us CBOs, not primary care providers. We do SDH work. Are we caught in the middle again? Hashtag undefinable. Melinda, I think it'd be great for us to better understand your unique situation. Why don't you reach out to us and we can set up time to chat. Does DOH plan to assist in data requests? We want to support this effort, and if there's a data request, please reach out to us and we're happy to work with you. As a CBO new to VBP, is there a list of contractors to connect with? Not yet, but as we begin to get more and more VBP contracts coming in that are level 2 or higher, we will look to do that. it's a good takeaway for us is to think about who they should contact. But right now, I think the best place for the CBOs to go is to contract plans, and we definitely do have that contract information, and we can get that out. How are CBOs, and the other place to start is the PPS. We can certainly provide you with contact information for PPS. How are CBOs able to show their worth given relatively small numbers of people they work with and compared to general population? Also, the current VBP measure that supports social determinants are not P for P. The MCOs are not able to collect them. That's true. Not all the measures yet are collectible that we want to do. That said, we think there's ample opportunity even in small demonstrations for the CBOs to demonstrate their worth. It was also one of the things that we're hoping for out of these innovation grant programs that the PPS have launched. That's another opportunity to demonstrate worth and look to be things that could be scalable. But that's part of the reason why we did not actually require sort of a scale requirement on these contracts, is to make sure that we gave opportunity for piloting of ideas so that we don't build up a lot of program capacity and things that may not work. How will attribution be made when it comes to considering SDH organizations contribute to outcomes and how they are shared savings? Ultimately, it's up to organizations. We do not have any attribution requirements. In fact, as I said, the actual contract between the provider and the between the tier 1 CBO and either the plan or the VBP contractor doesn't actually have to be value based. Doesn't actually have to have an attribution logic to it. But that said, it is so it's a lot of flexibility there, and that's by intent. Our contracts on a yearly basis are years based on calendar year or fiscal. It's really up to the providers as they enter into these arrangements with plans and CBOs. We think at the end of the day, a multi-year contract is preferable, but we do not have a requirement on it. It could be a single one-year contract. I do want to emphasize, though, that CBOs will be expected to perform. This is not a free ride. This is not, let's do some nice things with some effort. I think there's definitely expectations here that if the effort's unsuccessful, that the contracts could be terminated. Wow, that's a really long question. I don't think I can read it all in terms of, but it really relates to the prevention agenda and premature births and such. But I think overall, particularly as I mentioned, one of the areas that we're interested in is the maternity care bundle, particularly for large maternity care providers. I think absolutely huge opportunity for CBOs to partner to address the social determinants of health that relates specifically to birth outcomes. Next up. Not a question, but a comment. Further clarification on exactly what qualifies as tier 1 would be very appreciated. Absolutely, we will provide that. I think that's obviously one of the bits of feedback we've gotten very clear is to get you that very clear definition of what that is. Next up is Judy. You did submit 7 questions in advance. They're not being addressed. Please answer my questions. Judy, we're answering all the questions that are coming in here for those who are on the thing and heard the presentation. So we're answering those, but we will answer all of the questions that you answered and all the other questions we received in advance. We will be answering those if time is allowed, but it looks like we're running out of time here. It's getting close to 11. But we'll answer those and other questions we get all in writing and put those out to everyone. Next up is, I understand prospective payments theoretically can be advantageous for all reasons stated. Is there data to support these theories? There is definitely prospective payments taking multiple forms, including for the, say, primary care providers, particularly in places like New York City. It's become more commonplace. I think overall it's been effective, but we certainly can look to see and pull some data in terms of it. We think overall value-based payment has a very strong research base to support that it is superior to fee-for-service. And I think that, but the idea of global payments that are prospective is a less common phenomenon, but certainly there's some research done, particularly in areas like some of the Medicaid, more advanced Medicare pilot programs that have led to some measurable outcomes improvements. At the beginning of the session, it was said that 35% of payments are value-based. Is it 35% of all payments? So it's 35% of payments must be level 2 or higher value-based arrangement. In terms of value-based payment overall, which including level 1, the goal is 80%. And that's basically the dollar value of the contracts that are signed, expected dollar value of those signed contracts is what we mean. Next up is the shiny working together with New York State on connectivity issues. The answer is absolutely yes. The RIOs, PPSs, shiny, lots of good active work going on, trying to address the need to share information amongst providers. That's a clear goal of DSRIP, and we definitely believe that the gains we will achieve through that effort will be leveraged in VBP. It was mentioned that there are ways to limit downside risk for providers in level 2 arrangements. Can you expound on this and or provide examples? So many happy to provide. I would suggest that you go to VBP University for more information, but there are lots of different vehicles, that including ones that exist today, with downside risk arrangements. In some cases, there's corridors, there's caps put in place. Sometimes the insurance company, the MCO, provides risk mitigation strategies, lots of different forms that are taken and available. So we have 1 minute left here, so I'll take one more question. And as I said, we'll try to get the remainder here, including the ones we received in advance. I'll get those all out. Will DOH be mandating the assessments and the quality outcomes for each SDH category? How do CBOs with experience participate in informing SDH assessments and quality outcomes? So the bottom line is we had a very broad representation of CBOs and others in the work group that developed the recommendations. And one of the elements, one of the things that was discussed by that group was that we really didn't want to mandate the assessments. There are actually multiple assessments already in place. We also did not want to mandate which interventions and what measures would be used because there's really a need to experiment here. We want to try lots of things in different communities. We also anticipate that, that these arrangements will take different size. Some of the value-based payment arrangements will be for large numbers of people. Some of them will be for relatively small types of groups of people. Some will be homogeneous, some will be heterogeneous. Some of them will be in rural areas, some will be in urban areas. So as a result, we anticipate that we want to give flexibility in this effort. So with that, we've come to the end of our 11 o'clock hour. Now it's on 11. I want to thank everyone participating. Apologies, we couldn't get to every question today, but as I said, we will answer all of the ones that we received, both here as well as the ones we received in advance, and look forward to addressing those and getting those out to everyone. As I said, please contact us. Emails, I think, are now, can they see this now? Yep. So as I said, for sort of general questions, comments, if you want to talk to us, want to provide feedback, use the MRT Support Housing email. If you have specific contracting questions, use this email as well. But look forward to much additional dialogue. Definitely coming out of this, we will get out to the field, the survey, to begin to build a database of Tier 1 CBOs. Also, we will get out to all of you, particularly for the CBOs, contact information for plans and for PPSs, and also want to get out to all of you a very clear definition of a Tier 1 CBO, just to make sure that everybody's fully aware of what that requirement is. So very excited, a lot of work ahead of us in this area, but thanks for all the interest, and look forward to continuing more conversation on this important topic. So thank you very much.